On behalf of the European Association for the Study of the Liver, we welcome you to the Best of Cholestatic and Autoimmune Liver Diseases at the International Liver Congress 2016. After the advent of a curative treatment for hepatitis C, the attention of hepatologists is now focused on other equally important liver diseases, including cholestatic and autoimmune liver disorders. In fact, at the ILC meeting 2016, over 100 papers on these conditions have been presented, and there are at least 11 sessions dedicated to these problems. The research which has been presented encompasses basic science, but clinical research as well, on diseases like primary biliary cholangitis, primary sclerosing cholangitis, autoimmune hepatitis, IgG4-related disorders, as well as other less common cholestatic liver diseases. Diego, do you want to give us a summary of what we thought was important in primary biliary cholangitis, now called?
So let's call it primary biliary cholangitis, with its current name, used to be primary biliary cirrhosis. So regarding PBC, a lot of focus was on one of the debilitating symptoms, which is pruritus. There was an interesting multi-center study between USA and European countries, and was aiming at investigating whether adding maralixibat to UDCA would improve pruritus. And what happened is that it did not. So drug and placebo groups had no statistical difference. What was important is that the lack of statistical difference was due to the very powerful placebo effect. And this was the point that was discussed most when the paper was presented. A very strong placebo effect, which is important in this paper and probably also in other papers where pruritus is tested.
It just shows how a subjective symptom like itching is difficult to quantify, and it's difficult to relate even to the physician. So the placebo effect is really very strong.
Always on pruritus, a Polish group reported their study using plasmapheresis. It is something that was used when we were young doctors. And what they've shown is that it is effective, still is effective. The pruritus goes away. The alkaline phosphatase and all the cholestatic biochemistry improves, but that lasts for 1 month. After 3 months, we are back to square one, and the pruritus comes back. So we have to put on the scale the difficulty, if you want, in doing plasmapheresis, which is not without adverse effects on the one side, and the beneficial effects obtained by this procedure. The group of Albert Perez here in Barcelona reports that severe itching improves with the use of benzafibrate and recurs when the benzafibrate is stopped, so indicating that the benzafibrate is indeed effective. The fibrates have also been used as an add-on treatment by the group of authors in Vienna, in Austria, who observe an improvement of the cholestatic enzymes, gamma-GT and alkaline phosphatase, in 2/3 of their patients after they added the fibrates. On the other hand, if you want, David Jones from Newcastle and his group found that long-term treatment with fenofibrate together with UDCA does not improve the projected survival of PBC patients as measured by the UK PBC score.
Yeah, do you want to say something on obetocolic acid,
yes,
which is obviously
obetocolic, OCA in short, is a selective FXR agonist, farnesoid X receptor agonist, has been randomized in a placebo-controlled trials, but unfortunately, what happens with this drug is that pruritus, itching, is a major side effect. So what they try to do is to use this drug at low doses and increasing the doses, starting with 5 milligrams a day and going up to 10 milligrams a day. By doing this, the side effect of pruritus is diminished. Does not disappear, but certainly it is diminished. There was a global PBC study group who reported that patients transplanted for PBC, when they've been transplanted, if there are signs of cholestasis or sign of hepatitis 6 months after transplantation, in this patient, primary biliary cirrhosis will recur.
This is certainly an important information. It's a simple information, but it's quite important because obviously these patients will be looked after with more care and predicting the possible recurrence of disease.
Yeah. Turning to more cerebral things, more brainy things, let's talk about genetics. There have been several GWAS studies showing that interleukin-2 receptor, beta-2 gene, predisposes to primary biliary cirrhosis. Interestingly, Dr. Wosik, her colleagues from Poland, reported that a single nucleotide polymorphism of this gene are associated, one, with elevated levels of anti-mitochondrial antibody, and two, with the presence of cirrhosis. There was also an intriguing report from Lucchino Chessa and his group Sardinia in Italy that showed that oral bacteria, if you have oral bacteria in your mouth, but if you have an abundance of it, you are predisposed to primary biliary cirrhosis and to autoimmune hepatitis, because patients who have these two conditions have a flora in their mouths much more abundant than the control population. But I think it is time to talk about autoimmune hepatitis.
Yeah. Autoimmune hepatitis is a disease which has been really recognized for several years now, since the 50s. And it was believed to be affecting patients only in the Western countries, really. But now it's quite clear that it is present worldwide. There weren't an enormous number of papers on autoimmune hepatitis at the ILC 2016, but some of them are very interesting, and they focus on the acute presentation of this disease. The disease was considered in the long past a chronic disease, but in fact, quite a number of patients present acutely. And a paper from Japan was particularly interesting because in Japan, it has been said that the autoimmune hepatitis is actually very mild and post-symptomatic, while in reality, they show that a high proportion of their patients presents acutely. And very often are not recognized because they do have serological and histological variants compared to the normal presentation of autoimmune hepatitis. So it is important to be aware of that and therefore to treat them appropriately. There were paper actually that were focusing on the severe acute presentation of autoimmune hepatitis. This is also important because the patients can present with almost decompensated liver disease, and both a patient from Argentina and a patient from the United Kingdom did show that these patients, if diagnosed appropriately, they respond really very effectively to steroids and they have a good prognosis.
But is this new?
This is not really new, but certainly it's recognized very well in the pediatric population and has been published in the pediatric population very well. But it's important that it is stressed again and again because many patients who present with severe acute hepatitis are not really considered to have autoimmune hepatitis. Therefore, they are not treated timely with steroids.
But when transplant should be considered?
I think what has been, is not said in these papers in particular, but it is now well recognized that a trial with steroids for about 5 days to see whether the patient has a response, particularly if there is a severe coagulopathy, it's important to actually see whether the patient responds. If the patient doesn't respond and coagulopathy gets worse, then probably transplant is the answer. There is a paper from Dr. Cansado in Brazil, which really addresses a point which is important. When there are patients who have got an abnormal, unfavorable azathioprine metabolic profile, and they are unable to use azathioprine the normal way. Therefore, they don't respond as well as other patients to azathioprine, which is an important drug for the treatment of autoimmune hepatitis. What they show, or better, they confirm that the addition of allopurinol to the azathioprine, and particularly allopurinol with a decrease in the dose of azathioprine, is well tolerated and allows to reach a good response in patients who were not able to do it before. There are two papers from Padova, Italy, which are interesting. They confirm previous data, but they are actually interesting. They compare autoimmune hepatitis in children and adults, and they confirm that children have a much more aggressive disease than adults, but that the prognosis response to treatment is similar. They also show, like in other papers, that about 20% of autoimmune hepatitis patients do have associated autoimmune disorders like thyroiditis, Sjögren disease, and vasculitis. Interesting, they don't mention inflammatory bowel disease, which I think would be a different point altogether. But patients with this kind of associated autoimmune disorders, in fact, do respond equally well to steroids and do have the same good outcome as patients who do not have the associated autoimmune disorders. I think there is also a very interesting study from Sheffield. It's a retrospective review of their autoimmune hepatitis patients, and they look at the development of liver and non-liver malignancies. And they find that the patients with autoimmune hepatitis have an increased risk of developing both hepatic and extrahepatic malignancies. But the risk is really associated to the length of time they were treated with non-steroidal immune suppression. So steroids seem to be safer than the non-steroidal immune suppression they are given.
That's interesting.
Yeah. I think that's it for autoimmune hepatitis. Do you want to say something on the primary sclerosing cholangitis?
Let's turn to primary sclerosing cholangitis. As you know, a debilitating chronic liver disorder of unknown etiology and poor response to the current treatment. There was an interesting large multi-center European study, and that was based on investigating whether histological scores could help in predicting the outcome of PSC. And they tested three well-known histological scores. One is the Ishak score, one is the Nakamura score, and the third is the Ludwig score. And what they found, comparing the three scores, is that the Nakamura score scores better than the other two. So what they are proposing is to use this score in predicting the outcome of primary sclerosing cholangitis.
On the other way, on the other side, Nakamura scores also includes biliary components in their scoring, so they are more obviously germane to what sclerosing cholangitis.
And in fact, they said in their presentation, sclerosis,
bile duct damage.
Bile duct damage
and copper deposition.
Yes.
So essentially, they include
ductopenia.
Ductopenia. They include sclerosing. They include copper binding protein, which are suggestive of biliary disease.
There was also, on looking at the outcome, a presentation by the group of Olivier Chazouillère. Christophe Coppershaw should have presented, but was not there. So Olivier Chazouillère himself presented the paper. And what is shown is that by adding together FibroScan and magnetic resonance, you get a much better prediction of outcome than using the two techniques on their own. So put them together and you get a very good outcome prediction. An outcome prediction that can be also predicted, if you excuse me repeating myself, using some serological markers. There was a group a European group, and Nielsen presented their results. And what they showed is that if you look at CP3 and CP5, which are markers of formation of collagens, and if you use them together, this was important in the presentation because it was not written in the abstract, you have to have the two together, you can predict very well the outcome of primary sclerosing cholangitis. So there are serological markers in addition to investigation which are instrumental, like the one described by the French group.
There were interesting reports also possible treatment. You said that PSC is almost impossible to treat or very difficult to treat, but there are some new things, aren't
Yeah,
there?
there were some new things, and was very interesting. The report from Calgary, Bertus Eckstein used to work in Birmingham, now has migrated to Calgary, has reported that using a monoclonal antibody against the integrin alpha-4 beta-7, you can treat primary sclerosing cholangitis.
Or at least you can have a biochemical response.
You can have a biochemical response, and for biochemical response, what it was looking for was normalization of alkaline phosphatase, or at least 50% improvement. And this it got in 76% of the patients in the abstract, in 63% in his own presentation, so has gone down a bit, but 63% of the patients were able to respond to this particular drug, which is called vedolizumab. So it is a monoclonal antibody. And there is the possibility of using this drug. They did not report side effects. These cells expressing the alpha-4 beta-7 get the imprint of alpha-4 beta-7. This is an integrin when they are in the gut. When they go to the liver, they are there to do damage. And by using this antibody against the integrin, Bertus Eckstein was able to show that they can improve the conditions. There was also a paper presented by the group of Michael Trauner, really presented by Michael Trauner himself, and they've been using in a phase 2 placebo-controlled trial NOR-UDCA. And what they found is that NOR-UDCA works. That is a phase 2 trial. We need to have other centers to try it, but this is good news for patients suffering from PSC. A paper that was buried somewhere that I found very interesting, very, very interesting, was from Jendrek and reported from several different groups, and that there is an antibody of the IgA class. Normally they are of the IgG class. This is of the IgA class, which is directed against pancreatic major glycoprotein 2. And what he found is that this antibody is present in 50% of the patients, and he could show this in 2 different cohorts, a Norwegian one and also a German one. If you think that in primary sclerosing cholangitis there are no recognized markers, this single paper is a major advance, even, as I said, was buried somewhere and difficult to find. But as far as PSC, I think that we have summed up the novelties. Maybe IgG4-related disease is what we want to talk about next.
IgG4-related disease is really a little bit of a mystery that was originally reported from the Far East, but then it has become very clear over the last decades at least that it is a disease that affects the whole worldwide, really, patients worldwide. It is a disease which, however, has a different behavior in different countries. There were 2 papers very, very interesting, because one was from Japan, so a country where the condition had been recognized for a long, long time, where actually the first description originated, where they actually follow a huge number of patients, well over 400, and they all respond beautifully to steroids, and they have an excellent long-term prognosis. On the other hand, there is a paper from the United Kingdom with a lower number of patients, but still pretty large number, and they in fact do not show such a good, fantastic result. They show a lot of relapses in these patients, and also they have a lot of side effects from the steroidal treatment, and the prognosis long term is not as good. Now, this is interesting because obviously it suggests that although the disease is similar or identical, there is definitely a geographical, ethnical, and environmental difference, and these differences do make the disease different in different countries.
So the phenotype is different in Japan and in Europe.
In United Kingdom. I mean, obviously, we need more of these papers.
United Kingdom is still in Europe, so
United Kingdom, but we really need more series. But I think it is very interesting because also it shows, you know, maybe there is a genetic component, but certainly there isn't an epigenetic component as well in this kind of condition. I want to finish with something which is dear to my heart, which is biliary atresia. I am actually a pediatric hepatologist. So
it's a pediatric condition.
It is a pediatric condition, definitely. And biliary atresia used to be a lethal disease, but now a large number of children who with biliary atresia after Kasai portal enterostomy do become adults, and they actually go into the adult services. And one thing, there are two problems here. One is the adult hepatologists are not very familiar with the condition, but also what is important to try to identify early those patients who are going to do well or those patients who are going to decompensate and require transplantation. There is an interesting paper from King's College Hospital in London where what they did in over 100 patients with this condition, they applied the PSC Mayo score, which was done for primary sclerosing cholangitis.
So a different disease, so they apply criteria from a different disease?
They apply criteria from a different disease, but don't forget that biliary atresia is an extreme form of sclerosing cholangitis. Okay. So they applied the Mayo PSC score to these patients at the age of 18 years, and they found that this score predicts very accurately the outcome. So that patients with outcome
in terms of survival,
mainly need for transplantation, the compensated liver disease and need for transplantation. Hopefully survival now, obviously with transplantation is going to be good. So, and they therefore suggest that if there is a intermediate or high Mayo PSC score, these patients have to be followed up very closely. I think we have now underlined the work which we found most interesting at the ILC 2016, but you obviously can find all the work on autoimmune and cholestatic liver disease in the liver tree. Thank you.
Thank you.